Hi everyone, welcome to another Monty Hart lecture. Today we have a highlight, I think, of our lecture series. We have Dr. Eugene Braunwald, who will be speaking about hypertrophic cardiomyopathy, the past, the present, and the future. Dr. Braunwald really needs no introduction. He's an icon in cardiology, but I think it's worth spending a couple minutes just to introduce him. Dr. Braunwald is a distinguished Hersey Professor of Medicine at Harvard Medical School and the founding chair of the TIMI study group at the Brigham and Women's Hospital. He was born in Vienna in Austria in 1929. He and his nuclear family escaped from Vienna when the Nazis annexed Austria in 1938. After 15 months in England during World War II, they immigrated to the United States and settled in New York City, where he attended Brooklyn Technical High School, New York University College, and School of Medicine, followed by residency training in internal medicine at the Mount Sinai and Johns Hopkins hospitals. His fellowship in cardiology was at the laboratory of André Cornard, Nobel Prize winner at Columbia University and Bellevue Hospital. Dr. Braunwald served as the first chief of cardiology branch, as clinical director of the National Heart, Lung, and Blood Institute, and as the founding chair of the Department of Medicine at the University of California, San Diego. From 1972 to 1996, he was chairman of the Department of Medicine at the Brigham and Women's Hospital. He was founder, board member, and the first chief academic officer of Partners Healthcare System that evolved into Mass General Brigham. Dr. Braunwald's early research focused on the control of ventricular function, and he was the first to measure left ventricular ejection fraction in patients. His group described the first neurohumoral abnormality in human heart failure, defined the pathophysiology of hypertrophic cardiomyopathy. In Canning studies, demonstrated salvage of ischemic myocardium following coronary occlusion. They defined myocardial stunning following myocardial infarction as well. As founding chair of the TIMI study group, he and his colleagues demonstrated improved patient survival with patent coronary artery, which led to the widely accepted open artery hypothesis. They were the first to show the benefit of preventing adverse remodeling on the infarcted ventricle with ACE inhibition. In the Prove It TIMI 22 trial, they demonstrated the benefit of more intensive reduction of low-density lipoprotein cholesterol in high-risk coronary artery patients, which has changed practice guidelines and favorably affected the lives of millions. Dr. Braunwald has received multiple awards. Science Watch has listed Dr. Braunwald as the most frequently cited author in cardiology with an H index of 230. Based on his contributions, Dr. Braunwald received multiple awards, like I mentioned, and honors, including Distinguished Scientist and Lifetime Achievement Award of the American College of Cardiology, Research Achievement, and Herrick Awards of the American Heart Association. He's a recipient of an honorary Doctor of Science degree from Oxford University and 22 other honorary doctorates. Dr. Braunwald was the first adult cardiologist elected to the National Academy of Science of the United States. The American College of Cardiology and the Heart Failure Association of the European Society of Cardiology each have an annual keynote lecture named for him. The Brigham and Women's Hospital has named its largest facility as the Braunwald Tower. At its centennial anniversary, the American Heart Association named Dr. Braunwald the father of modern cardiology. The living Nobel Prize winners in medicine voted Dr. Braunwald as the person who has contributed the most to cardiology in recent years. For all this and more, it's a real honor to have you here. Thank you so much for taking the time, and we're looking forward to your lecture.
Well, thank you very much. I'm honored by your invitation, and this, this is an exciting period for cardiology, and I'm very impressed that I'm speaking to the Einstein Center and the Montefiore Hospital. Both of these are very important sites of the development of cardiovascular science. Can I have the next slide? These are my disclosures. 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 These are my disclosures So we're going to be talking about HCM, and I just wanted to mention that this condition has been around for a long time. Actually, I came across 3 case reports that came out of France in the 1860s. Of course, didn't have a name, but the description of the hypertrophy and in the outflow tract of the left ventricle was exactly what we see now. And there have been occasional pathology studies over the years, but the definition of this condition, even though the name didn't change, the name changed, but the definition became clear on both sides of the Atlantic. Donald Tier was a pathologist in London at St. George's Hospital, and he reported in 1958 in the British Heart Journal 8 cases of asymmetrical hypertrophy, which he called a muscular hamartoma. And what he meant by that this was a growth of muscle. It was not considered to be a cancer, but 8 cases were described. And the pathological picture is one of bizarre and disorganized arrangements of muscle bundles histologically. And this is the illustration in this paper. And you can see in the center is the interventricular septum. And you see it is enormous in thickness. To your right is the left ventricular wall, and while thickened, it's nothing like the septum. Between the two is the LV cavity, and you can see that the leaflets of the mitral valve are present. So that's asymmetric hypertrophy. Now, at the same time, almost simultaneously, I was working as the director of the catheterization laboratory at the National Heart Institute at the NIH, and came across a patient, next slide, who had subaortic stenosis. Now, 1958, we have to move and think about what the world was like to cardiology. Open heart surgery had just begun. It was a big deal to do open heart surgery. And it was a risky procedure. And so we were looking at that time to find important changes which the surgeon was enthusiastic about fixing. And here are some tracings that we obtained from the LV cavity, and you can see the gradient on the outflow tract. And then the catheter on this pullback also enters the aorta. And it's quite clear that there was no further increase in systolic pressure. So we interpreted this as subaortic stenosis, and what was known at that time in 1958 was that a membrane was in the outflow tract, or the LV, which was an uncommon but definitely described subaortic obstruction. And we thought, as did the surgeon, that this should be easy to fix. This is a photograph of the surgeon. His name was Andrew Glenn Morrow, and we worked very closely together as a team. And he was a pretty relaxed guy, as you could see. I was in the cath lab when the patient whose tracing we just observed was in the operating room. And Morrow called me and he said, "You have to come up to the operating room." And I did. And for a relaxed surgeon, he was very tight and unhappy. He said there is no obstruction. He had stopped the heart with potassium citrate. And he said that the ventricle looks and feels as if it's hypertrophy, but there certainly is no obstruction. And then he put his index finger through the aortotomy and of his right hand, and then also entered the left atrium and pushed his other finger into the LV cavity, and the two fingers met. So there was no obstruction, and I was very embarrassed by this because I had sent him for surgery. In any event, he came down and after the surgery, and he said, "Well, I don't know what we did, but I did measure the left ventricular pressure." And he said to me that I was right. He had a big gradient, and we were puzzled by the idea of somebody having severe obstruction that couldn't be felt by a skilled surgeon. And we didn't know what to make of it until about 6 weeks later, when a second patient appeared with exactly the same thing. And so then we realized that we had come on something that had not been described before. And we published this in Circulation around the same time. We gave it a bad name, functional aortic stenosis. It's correct. It functioned like aortic stenosis. But what we called it was a malformation characterized by resistance to left ventricular outflow tract without anatomic obstruction, by Morrow and myself. And the statement was that, quote, "The obstruction to ventricular outflow is of such a nature that it is only operative in the contracting heart and was not apparent during the diastolic paralysis induced by potassium citrate." And here are the key words that we entered. "These features can only be explained by muscular hypertrophy of the left ventricular outflow tract of sufficient severity that flow is actually impeded during contraction. So that was our understanding at the time. And it was quite interesting. This was published in, observed in 58, the same time as you saw from the pathology. But other patients with this condition at that time showed up quite frequently, and we learned a great deal about it in a rapid period. Now, one of the first things that we observed was that the important genetic components. These are 3 catheterizations, pullback tracings that I got in the cath lab. The top 2 panels show the outflow tract gradient from the cavity to the outflow tract, and then no more change after passing the aortic valve of 2 sisters. And then their brother came in. He also had a heart murmur, and you can see, like his sisters, he had marked obstruction in the left ventricular outflow tract. And we recognize now that if you're looking at this as a genetic abnormality for of obstruction that exists in almost half of the patients with HCM. Another thing that we noticed very early in our experience is that the severity of obstruction varies all over the place. The first observation that we made, which was in 62, a long time ago, is that when the heart was stimulated by means of sympathomimetic drugs, there are hemodynamic alterations, namely an increase in myocardial contractility, however obtained, increases the severity of obstruction. And this is an example. You can see the date of the catheterization that I carried out was August 30th, 1962. And there are 3 components on this slide. On the left panel, A, you can see there is the LV cavity. And in contrast to the slide I showed you earlier, there is no gradient between the cavity and the brachial artery systolic pressure. Then I gave this patient a small dose of a beta agonist, isoproterenol, and panel B is the slow paper speed. And you can see that the systolic pressure in the brachial artery is falling, and the systolic pressure in the left ventricle is rising. And panel C shows this patient who had no obstruction when he entered the cath lab now had an enormous 100 millimeter per gradient between systolic gradient between the left ventricle and the brachial artery. So other interventions that make the heart smaller increase the severity of obstruction. And that's the key. And we have seen this very frequently with the Valsalva maneuver, which is a simple test that you can do in your office. And the murmur that's produced by the obstruction becomes apparent. Next. The next thing we discovered, we're now in 1963, and we had a fellow from Israel, Maurice Eigen, who joined us for a year. And Maurice and I studied 14 patients who were very similar to the other patients with HCM, but they had no obstruction, and it was not possible to give them obstruction. So we call those the first form of patients as OHCM, obstructive hypertrophic cardiomyopathy. And then there were 14 patients that came across that looked like them, but we couldn't provoke obstruction in them. And at the present time, to take a look at the patients with HCM that you see, and in general around the world, about 2/3 of the patients have obstruction either at rest or can be pushed into obstruction by a Valsalva maneuver, by exercise, by isopraternal, other interventions. And I think it's important to distinguish between these types. So if a beta-adrenergic agonist, isopraternal, created obstruction, you wonder what beta blockers might do. Now, in 1967, it was interesting that that was the year that beta blockers were discovered. By the way, they were discovered at that time by a British pharmacologist who won the Nobel Prize. Here is a small number of patients that was given propranolol, and they either were exercised, either on a placebo, double-blind, or given them propranolol. And we looked at the maximum number of minutes that they were able to run on the treadmill. And you can see that it's all over the place. But there were 4 out of the 9 patients who were benefited by getting the beta blocker. And that has been repeated many times, and the published information guidelines for HCM give the beta blockers a very important role. They're quite benign, and they tend, not in every patient, but they tend to improve symptomatology. So the other major form of early treatment was operative treatment. And this is Dr. Morrow, whose picture you saw before. And Lambrou was a cardiologist, and myself. We were looking for patients. We were studying them in detail, and we referred them to Dr. Morrow, who developed an operation which is shown here. This is through a myectomy, surgical myectomy, in which a portion of that gigantic, thick interventricular septum is removed. And you see that in panel A, top left, this is a double-bladed knife that Morrow developed. And his finger is shown in panel B, where he has made the incision and then he dilates it with his finger. And in panel C, D, and E, he removes this extra hypertrophic tissue. And in panel E, bottom right, you could see it is no longer causing obstruction. Now, myectomy goes well for experienced surgeons. And I think that the key word here is experienced. It will completely abolish hypertrophic subaortic stenosis, but I urge you to only refer patients in institutions that have experienced surgical teams, because it takes some practice for this to work. So the work that I began with Dr. Morrow was in 1958. In 1968, I decided after 13 years at the NIH that I wanted to get into more academic medicine. And I left the NIH to become chairman of medicine at a new medical school, UC San Diego. Before leaving, I worked with one of our fellows, Stuart Frank, and we looked at all of the patients with HCM whom we had studied during this 10-year period. And we analyzed them clinically and looked after them quite carefully, paid for them to come back to the NIH and so forth. So there were 126 patients that we had seen. Now, that at the time in 1968 was a large number. It's now tiny. At the Brigham and at the MGH, and frankly, at the Mayo Clinic, at the Cleveland Clinic, they will see 126 patients in a month. It took us 10 years. Now, 10 of these patients died during this 10-year period. And interestingly, 6 of these, the most common cause of death was sudden death, unexpected, and instantaneous. And that can be attacked now in patients with arrhythmias and can be prevented by inserting a catheter, which will actually shock them if they developed ventricular tachycardia or ventricular fibrillation. So looking back on that 10-year period, this is really what we defined. It begins in 1958, where we found there was obstruction secondary to muscular hypertrophy. In 1960, you saw these three siblings, familial association with an autosomal dominance. 1962, variability of obstruction with, in 1963, the first description of a non-obstructive form, which I said exists in about a third of the cases. Medical treatment with beta blockade we introduced in 1964. Glenn Morrow, our surgical partner, came up with a myectomy in 1964. I didn't show you an important finding, impaired LV filling. You have this thick ventricle with a small volume, and that restricts filling. And in 1968, the frequency, the most common frequency, was sudden death. By the way, I mentioned that in 6 patients, but there were 10 that died. The other 4 developed congestive heart failure with dilatation of the left ventricle of the cavity, which had been thickened before. And so there is a second phase in some of these patients. And at the present time, patients like that who dilate their ventricles, so-called burned out hypertrophic cardiomyopathy, these patients become candidates for transplantation. Okay, other very important observations came along, and the Seidmans, Christine Seidman and Jonathan Seidman, are a wife-husband team. And here comes from their paper published in Circulation Research. And you see 2 fibrils in this cartoon. At the top, the thin one in red is actin, and at the bottom, the thick one in green is myosin. And then you see the mutations of the genes that the Seidmans discovered in hypertrophic cardiomyopathy. You see 2 of them are encircled, their titles are encircled in red, and take a look at them because we will return to them a little later in this lecture. But in any event, these sarcomeric gene mutations are responsible for the sliding of the actin on top of the myosin and interfering with that. So you'll see that in a moment. But these are the sarcomeric gene mutations which have been described at the Brigham in cardiology and in the Department of Genetics of the medical school. So where are we at the present time? So this is up to now, it's all been the past. So what do we know today? Well, we know that HCM affects both sexes. It's seen about the same frequency in all races, and it's seen in all ages, in all places. So everything's all. So we understand, we think we understand this condition. It's not rare, but it is clinically underdiagnosed. The estimate prevalence is 1 out of 500 individuals based on imaging. Now, we're probably missing many cases because they may have no symptoms but carry the genes. But based on imaging and based on the family history, we have 1 to 500. The median age of diagnosis globally is the mid-40s. And we think that probably 2 cases are missed for everyone that's diagnosed. It potentially affects almost 1 million Americans, and certainly appears to affect 1.3 million Europeans that we know about. And I'll return to that point that we know about a little later. Well, as far as treatment is concerned, there are some interesting changes. You see the last 2 names, again, are the Seidmans in the departments of genetics and in cardiology at the Brigham and at Harvard. And they created a company and identified a small molecule, myocardial 461, which reduces contractility. Now, that's unusual in cardiology, to reduce contractility by decreasing and interfering with an enzyme, myosin ATPase. And in this paper in Science, they demonstrated that this small molecule suppresses the development of ventricular hypertrophy and the disarray of the cardiomyocytes in mice harboring the human mutations in the myosin heavy chain, which I had shown you earlier. So we call these mice with myocardial hypertrophy. And this drug, this small molecule, which have been labeled as mavacamten, has a very positive effect. Let me take you through this slide. There are 3 panels. They all show in blue the thick myosin filament, and they show in red the thin actin filament. And you see the connections between these two, and they're in red as well. On the left-hand side, the panel shows 4 cross bridge. These red things are the molecules that I mentioned before that cause the sliding of actin over myosin and contracting the heart. So that's the normal sarcomere. The center panel shows many more of these bridges, 3 times as many bridges, and that is full-blown HCM. When this small molecule is given, you can see that there is some return. It isn't completely normal, but it sure is much better than you see in the center. And the summary of this finding is that mavacamten is a first-in-class targeted inhibitor of cardiac myosin, which means it reduces the number of myosin-actin cross bridges and thus decreases excessive contractility characteristic of HCM. So this is a new approach to the treatment. It is early. This drug has been approved by the FDA, and one of the things that it does, and we have to be careful in using it, is that the heart is no longer as contractile. The increase in contractility disappears, and if the patient is overtreated, they can go into congestive heart failure. And the way to avoid this is to increase the dosing slowly, and every 3 months to repeat an echocardiogram and look at the volume of the left ventricle and either continue the treatment or interrupt it or simply reduce the dose slightly. And the experience has been that if you follow that advice, the patients will tolerate the drug quite well. So what do we know about this? Explorer HCM was a phase 3 study published in The Lancet 5 years ago. And the bottom line, you can see treatment with mavacamten improved exercise capacity, left ventricular outflow tract obstruction, and improved New York functional class 1 in patients with obstructive HCM. And I emphasize the O in this because it's not quite clear if it has any effect on HCM without obstruction. These patients received, this was a double-blind trial that was carried out for 30 weeks. And here are the three gradients that you see, three panels. It was very strictly followed. Patients received placebo or mavacamten. The placebo gradients are shown in red over the 30 weeks of follow-up. And the placebo, the mavacamten patients are shown in blue. Panel A shows the gradient at rest. And you can see that nothing much happened in the placebo-treated patients. There was a moderate reduction from a gradient that averaged 51 to 1 to 46. On the other hand, the patients who received mavacamten showed a reduction from 51 to 14. So marked improvement. The middle panel shows the gradient with the Valsalva maneuver. And the nice thing about the Valsalva maneuver is it provokes gradients like isoproterenol. And you can see, again, the difference between the placebo and the mavacamten. And the third panel in C shows the control observations during exercise. In red, again, you see only a slight improvement. Wouldn't expect to see a marked change, and we didn't see a marked change in the gradient. But in blue are shown the patients who were treated for 30 weeks with mavacamten, and you see they fell quite markedly. The gradient fell from 84 to 38. Quite effective. Now, very quickly, I'm going to show you that this has been confirmed. It's very important to confirm this. And a similar study was carried out in Japan, published 2 years later in JAMA Cardiology. And the findings were very similar. If anything, they were even more powerful. In orange, you see the placebo-treated patients whose gradients hovered a little bit over 80 millimeters of mercury. So these were very tight. And the dark blue represent patients on mavacamten. So we have two ends of the spectrum. We have the Western and the Eastern patients, and they both showed a good, solid benefit. So we put together a whole series of first-in-class inhibitors and published that in the European Heart Journal 2 years ago. Now, there is a family of these classes of treatments. We began with mavacamten, which was the first. The second one to come out is aficamten, and that was published about a year ago, also in symptomatic patients with obstructive hypertrophic cardiomyopathy. And it has very similar picture. You can't quite see it, but these patients, the endpoint in this trial was basically how far is there a change in exercise capacity? Well, that was the primary endpoint. You can see in blue the placebo-treated patients, no change whatsoever. And in orange, the patients who received the second drug in this class, aficamten, and that was significantly higher peak oxygen consumption. The same thing that was seen that I showed you with mavacamten on the gradients was also observed. But it's nice to see a slight difference in the principal endpoint, and they were just as strong with aficamten as they were with mavacamten. This is a summary, was published just a few months ago, of aficamten, and it really tells the whole story. So if you look at the top left, it's HCM sarcomere, and you're convinced now you know about actin and myosin, and you can see the excess of myosin cross-bridging. So on the left is shown a sarcomere, and you can see that's the HCM sarcomere, and you can see that 4 of these cross bridges have been studied, are present. On the right-hand side is an HCM sarcomere in a patient treated with aficamten. I think the first thing that you notice is the thickness of the interventricular septum, which you saw on the left, has diminished. And on the right-hand side in green, you see the changes. There was a reduction of left ventricular outflow tract, an increase in left ventricular end systolic, LV wall thickening is reduced. There is improved left ventricular diastolic filling, and there is a reduction of hypercontractility. By hypercontractility, we would say anything of that is higher than an ejection fraction of 70%, and that is certainly reduced. We don't want to see it going below 50. And I think this slide also emphasizes the changes in the echocardiographic measures that are associated with changes in maximal PbO2 and other outcomes in aficamten, and we could say mavacamten treated patients. Next slide. So now this really brings us to the future. We have learned an enormous amount about HCM over the course of the years. And from my perspective, since 1958, which is when we discovered those first two patients. Certainly the genetics have been very important. Imaging is really essential, and both echocardiography and CMR are routinely used. But where do we go from here? Well, I will show you just two slides. The first one is prevention. How do we prevent this? Well, the Seidman's creation. Yeah. And they're dealing with human HCM in mice has been a very important start. Tenaya is a California company which has dealt with these HCM mice, and they have replaced the mutated human gene that encodes myosin binding protein C, which I pointed out to you. This myosin binding protein C increases the cross bridging. And it worked on these mice. And what's exciting to us in clinical cardiology is that there is a clinical trial that is ongoing in patients with HCM run by this company and colleagues at the Cleveland Clinic. And then I'll show you, this is our last slide, and it is the first AI algorithm for HCM. So that's now almost 2 years old. So this new artificial intelligence algorithm for earlier detection and management of HCM. I said to you that for every patient who's discovered, there are 2 others that are mysteries. Well, once we have alternative appearances with AI, it is going to be possible to discover many more, because the period of these patients where they cannot be discovered by physical examination, and if they have positive genes, then they may develop outright disease when you see them too late. And therefore, if we can find family members at an early time, then we can follow them much more closely. And this would probably mean a doubling or tripling of the number of patients who have this condition. Thank you for your attention.
Thank you so much, Dr. Braunwald. That was an amazing lecture. I love the part of the past, and I'm sure our fellows loved it as well, and how important it is to realize all the work that has gone to know what we know nowadays. So thank you for that. For everyone, please put the questions in the Q&A and we'll go through them. I would like to start with one question. Before we use imaging to diagnose hypertrophic cardiomyopathy together with the clinical findings, but the imaging findings are usually later in the phenotype. Now we have genetic testing that allows us earlier identification and new medications that are disease modifying. Do you foresee in the near future that we'll start treating earlier patients?
A very good question. So I think these Camptons, as we gather more experience with them, may change. At the moment, they don't, but they may change the natural history. I think that's what you're getting at. And there are trials that are starting now that are looking at patients either who have no obstruction or where the obstruction isn't severe, and can they tolerate these drugs? I think something that stands in the way of this is that, like so many new drugs, it's quite expensive. But if that's what the patient needs, then I think the companies that make these drugs would enormously increase their volume. So it's appropriate for them to pay for the trial. So I would simply say, let's stay tuned to this. It may well change the natural history.
Thank you very much. A wonderful answer. We have a question from Scott Monrad, who asks about how does one balance the choices of beta blocker, calcium channel blocker, and the Campton therapies. And I will add to that of surgical interventions in the time of Campton therapies.
Well, in other words, are you asking how do these two methods of medical therapy differ? The guidelines, which came out about a year ago, indicate that because there's so much information about the beta blocker, that's a useful thing to begin with. You can always stop it and go forward, so that the opening should be with a beta blocker. And many patients, let's say patients who are New York Heart Association class 2, they don't have, they've never fainted, they've never had ventricular arrhythmias, they have a loud murmur, but that's all. They can probably be started on a beta blocker and followed closely. On the other hand, if they are a late 2 or an early 3, and the obstruction on cath or on echo or CMR is serious, then I think probably you're going to end up with one of these candidates.
Thank you very much. And on the question on surgical or catheter therapies with the existence of the Camptons, should we always attend Mavacamten first before referral for surgery?
You answered it.
Hampton's before referral to surgery.
Oh, Campton's before surgery. Yes. Yes, I think that there has been one trial that showed that patients who required surgery, if they were followed by Campton or placebo, the placebo-treated patients over several months required surgery. And the Campton patients, after following them for several months, were no longer candidates for surgery because they improved substantially. So it's a very good question, and I think that I think we could probably reduce the number of patients who undergo the surgery.
Okay, thank you very much. We have a comment from Dr. Skenone that runs our Hypertrophic Cardiomyopathy clinic. He says, thanks, Dr. Braunwald, for all your work in the HCM space. All we know about HCM is thanks to you. So with that, I'd like to close the lecture and thank you again for your time and for all the data you've gathered and all the knowledge to inspire many generations. Thank you.
Well, thank you very much. I appreciate it.
Bye-bye.